What? Hello.
Yeah, Jwalansi, your voice is audible.
Okay, okay. Yes, yes. Okay, okay.
दिख रहा हूँ पूरा मैं। Wait, that's
Why is my video not working? एक minute.
Yes, sir.
Why is my video not working? एक minute.
Yes, sir.
Jolent, can you hear me?
It's quite audible, sir.
Okay, I'm just trying to get my video sorted out. पता नहीं
Uh,
video not
yes, sir.
search.
We have a time, sir.
Okay. Jolent, can you hear me?
Hi, Amit. Amit, is it Amit? Yeah, who's this? Hello.
Yes, ma'am. Very good evening, ma'am.
Yeah, good evening. You are? You
Ma'am, I
are?
am from Corona Remedies and myself, Jwalant Patel, ma'am. Yes, ma'am. And our medical head will is already joined, ma'am, but facing some video.
Dr. Amit.
Just
Is it
yes,
Dr.
Mr.
Amit?
Yes, Dr. Amit Babu, ma'am.
So good evening, Dr. Lalita. I'm just
Yeah.
trying to sort out my video.
Yeah,
It's
no
not turning
problem,
on.
Dr. Amit. Yeah, take your time, no problem. We have some more time to start.
By 5 o'clock we will start, ma'am.
Yeah.
Yes.
So meanwhile, you want me to take my PPT out, or I mailed it to you?
If
What
you
do
are
you want?
able to share your screen, then you can, ma'am. I already shared
Yeah,
the.
let me just check.
Yes, ma'am.
Ma'am, this is Durga Prasad, madam. One small change. Dr. Samyukta madam attend అవ్వట్లేదు మేడం అది మేడం కొంచెం వేరే ప్రొసీజర్ లో దేంట్లోనో ఉన్నారంట.
Okay, it is only talk, no, it is not
Yes, yes.
interactive session. I will talk and afterwards Dr. Meera will talk. That's the end of it.
Yes, yes, ma'am. Yeah, yeah.
I'm just trying to get my PPT out. Let me check.
Finally got it.
Oh,
Hi.
So hi, Dr. Lalita, in person. There was a little glitch in my video and I sorted it out.
Yeah, that always happens.
Yeah.
Yeah, now what do I do? So I shouldn't go on to slideshow as it, isn't it?
If you like, you
yes, ma'am.
can test it right now by sharing it.
No, it's already, sent on. Yeah. So, but you can't see this, no? My slideshow?
No, ma'am. Not yet.
No. Okay, let me keep it. Let me minimize this and then I'll go back to Zoom. And then share screen. Yes. Fine. Can you see
Yes,
now?
ma'am. Visible.
Yeah. Then.
Yes, visible.
So now I don't need to share now. What do you want me to do? I'll minimize it and keep it ready, or I'll just keep the projection ready. What do you want?
Yeah,
No, ma'am.
you just
Flow is
minimize
there.
it.
Yes,
So
sir.
I'll just keep it like this because that my talk is the first one. You don't want that?
No, no, ma'am.
So
We will,
minimize and
yes,
keep.
with the flow, we will invite you to share your screen, then we'll start.
Okay.
Yes.
So again, the technical glitch, if it gets delayed, is that fine for a
Then I
couple
will
of
share, ma'am. No problem at all.
No
why am
problem.
I getting this again? Zoom, join a meeting. I have to. What do I do with this? Why am I getting that again? Fine now?
Yes, yes, fine. Absolutely
Yeah.
fine, ma'am. You can remove your screen share,
You
ma'am.
can minimize the presentation.
Minimize, no, already? No?
No,
No,
you have to
minimize. Click
stop
on
sharing.
minimize.
I'll stop sharing the screen,
Yes.
okay? Fine.
So good evening, Dr. Meera. Welcome.
Good
Hi,
evening.
Meera.
Good evening. Hi, ma'am. How are you?
I'm fine. How do you?
And we will start by 5 o'clock with couple of minutes, ma'am.
Sure.
Yes.
Long time, Meera.
Yes, how are you, ma'am? On well?
So they were just telling me there's no moderator, so I would just finish my talk and then you can go on, isn't it?
Yeah, no problem. Done.
But in case there are any questions, if you can just hold on for 2-3 minutes
will
after
wait.
your talk.
Yeah, we will wait. We will look at the chat also, and then if there's anything, we will
Right.
ask.
Sure. I'm just going to, before introducing you, I'll have just 2-3 very simple slides to highlight the importance of such webinars and experts like you. So it will not take more than 2-3 minutes.
No problem. So right now only we are
I've
there. no?
also emailed all my presentations and video, so you can run from your side.
If you are able to share, ma'am, from your side, it's fine. I have given.
Both are fine. Both are
Yes, you can share from your computer, ma'am.
done.
Yes,
No
ma'am.
problem. Easier.
So can start, ma'am. I will start just sharing my screen.
Dr. Patel, again clarify for me, the audience are, the target audience are urologists,
Yes, ma'am.
gynecologists,
We have
urogynecologists.
given access to the faculty only, and the rest whole video will broadcast on our YouTube channel, ma'am. It's our internal channel and broadcasted on YouTube, ma'am.
No. Okay,
Yes,
right
if
now
any
actually
query
it is
will
not
be-
live, it's not.
Yes,
going
it's a
live.
live program, and once any query raised from their end, I will post it over here also, ma'am.
Okay.
Yes, ma'am. So we can start, ma'am. Yes. Very good evening to all of you, and I welcome all of you. Regards from Corona Remedies. Very warm regards, and today's Viewpoints in Urology under the banner of Vieu. We are invited all of you in a live webinar from Corona Remedies. And the topic we have taken for today is the very crucial point in terms of urology, that is overactive bladder, in terms of the management of overactive bladder. And why we have taken this, because many patients, even when they are doing different things like uh, uh, shopping, traveling, or anywhere they are going in social gathering, they are constantly thinking about urination. And in terms of here, overactive bladder could be the culprit and leading to many symptoms like urgency, frequency, or urge incontinence. So here the important part is the bladder, where we need to take a charge or maybe take a control to prevent such symptoms from the patient sides. So I welcome Dr. Amit Bhargav, sir, to take forward the session with the expert team to get more insights in overactive bladder and the management of overactive bladder. So I request Dr. Bhargav.
Okay.
Dr. Bhargav is a family physician working at Ahmedabad, and a medical consultant at Corona Remedies as well. He is a director at Heart of Medicine and ex-board member of medical faculty MUHS. Dr. Amit Bhargava has the MBBS in 1985 and completed his MD in 19.
Hello?
Yes, ma'am.
Hi, madam. So sorry I joined in late. Lalita, madam. Hi, madam.
Hi, who's this?
Samyukta, madam.
Yeah.
Hi, madam.
Welcome,
Sorry
Samyukta.
to join in late,
Yes,
madam.
No problem. We haven't get started. Don't
Yes,
worry.
ma'am. So Dr. Amit Bhargava completed MD in 1988 and both from MAMC at New Delhi. If you talk in detail regarding Dr. Amit Bhargava, a professionally diversified experience of more than 36 years in various fields like teaching, research at NIH, USA, R&D and quality assurance, IT industry as well in today's scenario. Of course, clinical practice in Baroda, Mumbai and Ahmedabad, and pharma advisor in many pharma companies like Alembic, Alkem,
అది పక్కన
Cadila,
పెట్టు ఈమె చదువుకుంటా
Hilder, Glenmark,
అవుతుంది
right? So I request Dr. Amit Bhargava sir to take this session further with the opinion of experts we had.
Okay.
Please, sir.
Thank you so much, Jwalant. I will just briefly take up 2-3 slides and not stand for much time between the experts like Dr. Lalita and Dr. Meera. Just let me share this. Okay, here we go. Is it visible?
Yes, visible, sir.
Perfect. Okay, so briefly, why is Corona doing all these web meetings and so on, so webinars? It's related to two central themes of experience and experts. Now, what is the link? We have all been through this professional lifespan spectrum. We've been students, we have acquired knowledge, we have become professionals, practiced, become successful. I'm sure everybody listening in is a successful practitioner. And some people because of their exceptional clinical experiences, have gone on to become experts, and they are universally proclaimed as experts. So there is a need for experts to share their exceptional clinical experiences to enhance the clinical outcomes in everybody's clinical practice. Because everything cannot be published, and experience least of all. So that often gets left out, and we don't talk about it enough. But there may be some fantastic success stories that each clinician has to share. And this is a forum that we are providing for such opportunities. Uh, so this is all about clinical practice enhancement. So RCTs and guidelines, these are the clinical evidences that we typically rely on to adopt or reject a particular therapy or procedure or whatever. But I'm not downgrading RCTs or guidelines. They are critical. They are the most important foundation for our practice. But clinical evidence is not enough for clinical practice. What is also required is clinical experience, which comes only with time. There is no shortcut to it, and it comes only with time. The more patients we see, the more experience we get. And this experience is what enables us to rise above guidelines. No guideline can tell us how to customize the therapy for that one patient sitting across the table. But our experience can. And that is why experience is critical. So in short, clinical evidence, very important, plus clinical experience is the hallmark of a clinical expert. And for today's meeting, we have two very renowned clinical experts. The first one is Dr. K. Lalita, MCH Urology, with academic achievements of 10 gold medals during MBBS. So she has been an academic stalwart right from the beginning. Top rank in MD, PGI, Chandigarh, first rank in state urology. Obviously, there have been a lot of papers, conducted a lot of workshops, and she is the assistant professor of urology in Gandhi Medical College, consultant urogynecologist for 25 years. That's a lot of experience, typical hallmark of an expert, and director of Lalita's Urogynecology Center. So welcome, ma'am. And the second expert that we have is Dr. Meera Raghavan, consultant urogynecologist and robotics surgeon. So you're going to get a totally different kind of flavor with this robotic surgery experience. She's from Apollo Hospitals, Chennai. She's secretary, Chennai Menopause Society. I mean, a society which I consider very important because I get these patients and they are really miserable and they have to be counseled, they have to be referred. So I'm sure this Menopause Society is going to pave the way for a lot of benefits. She's executive committee member, OGSSI, core committee member, Urogyne subcommittee, core committee member, GIBS, FEPPA, patron, Tamil Nadu FOG, core committee member of a number of bodies, fellow representative, director escort, Apollo's simulation critical obstetric team training, member specialist, committee, National Board of Examinations, very important responsible position, MRCOG, trainer and examiner, recipient of various gold medals in undergraduate and postgraduate. So we have not only a clinical expert, but also a serious academician, publications in national and international journals. So Dr. Meera, ma'am, welcome to you too. And with this, I will hand over to Dr. Lalita for her presentation. Ma'am, the floor is all yours.
Thank
I'll
you,
stop
Dr.
sharing.
Amit, for such a wonderful introduction.
Yes, ma'am. You can share your screen, ma'am.
Yeah, I'm trying to, but
If you click on the PPT icon, it will open up again. PowerPoint, sorry.
can you see? Am I visible?
Not yet.
Not yet, ma'am.
I wanted to keep it ready, but now I think Now? No?
No.
Oh, still not there. I think it's coming. Yeah, now we can see it.
Okay, fine.
Visible,
One
ma'am.
second, let me go to.
Just make it full screen.
Yeah.
Yeah, visible.
So thank you, Dr. Amit, once again for such a wonderful introduction. Urinary incontinence is the most common urological problem, affecting almost 40% of the women over the age of 50 years. Among different types of incontinence, stress urinary incontinence is the most common type affecting women. Stress urinary incontinence, I mean leakage of urine whenever the patient is coughing, sneezing, or bending to lift any object. In other words, any physical activity which increases the intra-abdominal pressure can result in urinary leak. It has a severe impact on the quality of life of these women as it affects every sphere of a woman's life, right from social, occupational, domestic, recreational, marital, and believe me, even spiritual lives. For example, women with severe stress incontinence do not like to attend any social gatherings. They almost become a social recluse because they live in a constant fear of wetting their clothes in public, because some of these women leak urine even when they laugh loudly. I don't need to tell you the woes of the working women with this problem, especially in a country like ours, where many women may not even have an access to a decent restroom. Even homemakers find it difficult to cope up because whenever they bend to lift any object from the floor, they start leaking urine. Sometimes a typical complaint from the homemakers is whenever they are in the kitchen cooking, that strong aroma makes them cough or sneeze, and then they start leaking urine and they have to leave everything and run to the toilet. Some women who tend to be obese, we keep counseling them to control their weight because we all know obesity can aggravate the problem of incontinence, both urgency incontinence as well as stress incontinence. But the poor woman cannot take up any activity of their interest, like skipping, dancing, jogging. Some young women these days complain typically that they are fine otherwise, but whenever they are doing aerobics or doing some strenuous physical activity in the gym, they start leaking urine. So naturally, they become sedentary, they stop doing any sort of physical activity, and the weight increases, and it's a vicious cycle. Some women have serious marital discords because of coital incontinence. You might be wondering how incontinence can affect spiritual life. Many of these women, when they're fed up of their problem, when they finally want to find some solace in spiritual life, poor women start leaking urine as soon as they kneel down to offer prayers, and in many religions, it's not acceptable to pray when clothes are soiled in urine. I had a patient few years ago who was a young widow who had a young school-going son. She came to me crying that after she lost her husband, her only solace was her religion, but she was not able to practice that in the way, the prescribed form, because she has kneeled down to offer prayers 5 times a day, which she is not able to do because of this incontinence. So I did a midwifery sling for that patient, and she became completely continent, and she was so grateful. So such incidents and such stories, give us more satisfaction than any financial benefits we might get. So these things, make us go forward in our tough lives. So you can see how severe impact the incontinence has on these women. Thus, a seemingly trivial problem for a busy obstetrician or otherwise a busy general practitioner, incontinence may look so trivial problem, but it can devastate a woman's life. Before we go on to the clinical management, let's take a brief look at the pathophysiology, because then only we can understand the basics of the surgical principles, various surgical principles. Previously, it was thought that the position of the bladder neck above the level of pelvic floor is the most important factor which maintains continence in women, because it helps in equal transmission of pressure between the bladder and urethra whenever there is a rise in abdominal pressure. This is called Enhancing theory of pressure equalization. But with childbirth trauma, when the pelvic floor becomes lax, the bladder neck descends below the level of pelvic floor. So the pressure equalization is lost and the woman starts leaking urine whenever there is rise in intra-abdominal pressure. This is called urethral hypermobility type of stress incontinence. But in some women, even when the bladder neck is in its normal position, they can have severe urinary leak with minimal stress like getting up from the bed or brisk walking. This is because of intrinsic sphincter deficiency, wherein the intrinsic smooth muscle sphincter of the urethra becomes incompetent. And also there is urethral mucosal atrophy, which is usually seen in postmenopausal women or sometimes post-pelvic surgery, post-radiation. For women with urethral hypermobility, the answer is simple. The correction is simple. We just have to suspend the bladder neck in its normal position. Like this. For example, this is Birch Kalpo suspension, wherein the bladder neck is suspended in its normal position above the level of pelvic floor by anchoring the periurethral fascia to the Cooper's ligament. This has been, the Birch Kalpo suspension has been the gold standard procedure for a long time, till the turn of the last century. I will discuss about this later. But for women with intrinsic sphincter deficiency, the Birch is not an answer because it is caused by incompetence of the intrinsic smooth muscle of the urethra. We have to buttress the urethra by a suburethral sling. Conventionally, this sling was a pubovaginal sling, which is placed at the level of bladder neck, and this sling could be fashioned out of rectus fascia or fascia lata from the thigh, or it could be any synthetic sling. When it is properly tensioned, this gives excellent continence rates, but there is a problem that some of these women, actually a significant number, almost 30% of the women after surgery will have voiding dysfunction requiring CIC or an indwelling catheter. You know, our Indian women, they do not like to have a catheter. They don't mind living with their incontinence, but if a patient after surgery needs a catheter, even when she becomes continent, the surgery is doomed to failure. Unlike their Western counterparts, they don't mind doing a CIC in order to remain dry. See, this pubovaginal sling is applied under cystoscopic guidance. See how the preoperatively the bladder neck was patulous, incompetent bladder neck. Once the sling is tied, suspended with optimal tension, so you can see beautiful coaptation of the bladder mucus of the bladder neck. But because of this problem of voiding dysfunction, for a long time, we, the urologists, urogynecologists, were in a dilemma as to what to offer to these women with intrinsic sphincter deficiency. So, as I said, at the turn of the last century, Ulmston and Petros has proposed what is called mid-urethral continence mechanism. As they've done various urethral pressure profile studies, extensive studies, they came out with a proposal that the maximum urethral closure pressure at the time of increased intra-abdominal pressure is observed at the level of mid-urethra, not at the bladder neck as was previously thought. So based on this, the mid-urethral continence mechanism, and this is brought about by how does the closure pressure increases at the level of mid-urethra? This is by a sling. It's like a hammock which supports the mid-urethra. That means there's a hammock which goes under the mid-urethra. This hammock is made of the ligaments, pubourethral and uretropelvic ligaments. So whenever there is pressure from above, the urethra is compressed against this board of ligaments. So the urethra is compressed, the lumen is closed, and there is no leak even when there is increased pressure. But again, with childbirth trauma, these ligaments can become lax, so there is no longer support to the mid-urethra, and urine leaks whenever there is stress, that is increased abdominal pressure. So the mid-urethral sling, what it does is it reinforces the physiological sling. So it reinforces the physiological hammock, thereby increasing the urethral closure pressure at the time of increased intra-abdominal pressure. I would say that the mid-urethral sling has revolutionized the surgical approach to female stress urinary incontinence because they're minimally invasive, they're highly effective, and also they're versatile in the sense that they're effective for both types of stress urinary incontinence, both urethral hypermobility type as well as intrinsic sphincter deficiency type. And no wonder they've soon become the new gold standard, replacing birth, which has been the gold standard for almost many decades. With this basics in pathophysiology, let's move on to the clinical management of these women. So the stress urinary incontinence is diagnosed solely by clinical evaluation, a detailed history, and a thorough physical examination. In the history, when a patient comes to us, to a clinician, she doesn't know what type of incontinence she is suffering from. She only says she has urinary leak. It is for clinician to elicit the answers from the patient so that we come to a conclusion as to what is the type of incontinence. So we need to know the timing of urinary leak, whether it's associated with any physical activity like coughing, sneezing, bending, running, jogging, or any physical activity which points towards stress urinary incontinence, or whether urine leak is preceded by a feeling of urgency, a compelling desire, and then the patient runs to the restroom, but in spite of she running, she would leak urine before reaching the restroom. This is called urgency incontinence. But many times the patient has both urgency incontinence and stress incontinence. It's called mixed incontinence. We need to go into a detailed obstetric history. As I said, multiple vaginal deliveries, difficult deliveries, instrumented deliveries are the underlying cause for stress incontinence. We also need to know whether the patient has diabetes or any other relevant neurological condition which may result in neurogenic bladder, resulting in neurogenic dead reserve overactivity, resulting in urine leak, before we offer them any active treatment, like any invasive treatment. We also have to look for any condition which causes chronic increase in the intra-abdominal pressure, like COPD, which causes the patient to cough all the time, or chronic constipation. Because unless we correct these underlying factors, we shouldn't offer them surgery. Otherwise, the patient can have recurrence of urine leak or persistent stress incontinence. Coming to the physical examination, this is again very important. As I said, stress incontinence is a clinical diagnosis. So the pathognomonic sign, I would say, is positive supine stress test. So the patient is asked to lie down in the supine position on the examination couch with a full bladder, and the clinician would inspect the external urethral meatus, and the patient is asked to cough. If the urine leak is synchronous with the act of coughing, we can label it as a case of stress incontinence. We also need to look for any significant pelvic organ prolapse, because this may require simultaneous surgical repair if we are planning surgery for stress incontinence. Also, for patients with higher degree pelvic organ prolapse, we need to look for occult stress urinary incontinence. That means the patient may not have clinical stress incontinence. She may not know that she leaks urine whenever she doesn't leak urine with physical activity, but we need to reduce the prolapse by a pessary or a vaginal pack, either during clinical examination or during urodynamic evaluation, to unmask the occult stress incontinence. Because if the patient has occult stress incontinence, about 40% of them may need continence surgery at a later stage. So we may not all the time do a preemptive continence surgery in patients with occult stress incontinence, but we have to counsel the patient that the possible need for another surgery later on after correcting the prolapse. The targeted neurological examination targeted to the S234 segments to rule out neurogenic bladder is very important. This can be elicited by looking at perianal sensation, anal sphincter tone, anal reflex. So if these reflexes are normal, then we can we can be less assured that the cycle S234 segments are normal, and probably it's not a neurogenic bladder. But this is very important to rule out any underlying neurological condition, especially in case of stress urinary incontinence, before we go in for any invasive. This is a $1 million question. What is the role of urodynamic evaluation in the management of stress urinary incontinence? According to AEA guidelines, it is mandatory before any invasive or surgical treatment, except in a small group of patients who would fulfill certain criteria, like patient has symptoms of only stress incontinence, no symptoms of overactive bladder, no voiding difficulty, and on examination there is urethral hypermobility, the supine stress test is positive, neurological examination is normal, and ultrasound doesn't show significant residual urine. If the patient fulfills all these criteria, then we are dealing with stress urinary incontinence. The probability is more than 90%. So we can safely skip urodynamic study before offering the patient surgery. But let me remind you that all these criteria fulfilled only in a small percentage of patients, less than 10% of patients with stress incontinence. So in the rest 90% of the patients, we need to do a urodynamic study before surgery. So how does this help? Why should we do a urodynamic study, since I said stress incontinence is a clinical diagnosis? It will help us to know what type of stress incontinence the patient is suffering from, so that we can choose the optimal surgical procedure for the patient. If the patient has urethral hypermobility, we can either offer a Birch Calper suspension if there is a concomitant abdominal surgery going on, or we can do a mid-urethral sling. But if the patient has intrinsic symptoms, we cannot offer her a Birch Calper suspension. So this may not be of great significance in the era of mid-urethral slings, but even in mid-urethral slings, if a patient has intrinsic symptoms, retropubic sling is a better option. And if a patient has voiding dysfunction along with stress incontinence, obturator sling is a better option. So it will definitely help us to choose the right procedure for the given patient. And also it helps us to predict the risk of voiding dysfunction after surgery, because if a patient on the preoperative urodynamics has decreased flow rates, there is a high chance that the patient would need a CIC after surgery. So this may have to be counseled to the patient. If, for example, you look at this graph, it's a urodynamic graph. Patient presented with stress urinary incontinence. There are no unstable contractions. But in the voiding phase, if you see, the flow rate is very less, and this is because of increased external sphincter activity. So this external sphincter, when the detrusor is contracting, it should relax. That means the detrusor, there is detrusor sphincter dysenergia. This term is given if the patient has underlying neurological problem. In the absence of any neurological problem, it would simply be because of dysfunctional voiding. So we have to train the patient to void normally, like the best position for these patients is dysfunctional voiding is fatting while voiding, and also we have to teach them pelvic floor relaxation techniques, take deep breath. So this is all called urotherapy without any medical treatment. So if the patient doesn't improve, then I offer her muscle relaxants like baclofen, and I take her for surgery only when her flow rates improve. Otherwise, there is a high possibility that the patient would need CIC after surgery. So this graph shows unstable, typical phasic contractions of the detrusor throughout the filling phase, which is suggestive of overactive bladder. So unless we stabilize the detrusor by antimuscarinics or mirabegron or combination, we should not take them for offer them surgery. Only after urgency and overactive bladder is controlled, if her stress incontinence still persists and still significant, then only offer the patient surgery. So I did my first mid-urethral sling in the year 2003, one of the first ones in the country. That was a prototype mid-urethral sling. This is a retropubic tension-free vaginal tape. You can see the Prolene mesh, ribbon-shaped Prolene mesh with the needle attached on either side. That's a introducer which would be attached to the end of the needle to drive the needle. I won't go into further details because my colleague Dr. Meera would be showing this procedure in detail in a little while. But I just wanted one point to be highlighted. Here, the needle goes through the vaginal incision, through the retropubic space. It comes out of the suprapubic incision. So there is, so what I'm saying, the complications may not happen in the expert hands like Dr. Meera, but there is a potential risk of injury to the bladder, bowel, and major vascular injury has been rarely reported with the retropubic sling. So now we have a modified needle. You can see this is much more slender, more surgeon friendly. So, but I would now be going to describe the transobturator tape. So the advantages of transobturator tape is the needle doesn't go through the retropubic space, so the risk of bladder, bowel injury, major vascular injury are almost completely eliminated. Here we can see there are 4 types of midurethral sling. The retropubic sling, either the needle goes from below upwards or sometimes it can come from up, above downward. Similarly, transobturator sling can be outside in or inside out. So there are certain common complications for all types of midurethral sling. The technical complications are usually intraoperative complications related to the needle passage. So they're different for retropubic and obturator sling, as I already discussed. Functional complications can be de novo, that means which the patient did not have before surgery, but she developed it after the surgery. It could be de novo urgency, which she didn't have. It's not mixed incontinence. She has first incontinence, but later on after surgery, she developed urgency. Or it could be de novo voiding dysfunction. These again are common to both types of midurethral slings, but there again, the incidence is higher with retropubic sling. And the long-term, most dreaded complication is erosion related to the mesh. Now we will discuss briefly how to minimize these complications in patients who undergo midurethral sling. So, as I said, not only the technical complications are less with transobturator sling, even the functional complications like voiding dysfunction and urgency are much less with transobturator tape. The reason being the transobturator tape, if you can imagine, it goes more horizontally. The obturator foramen is on the lateral aspect of the pelvis. So the tape goes more horizontally, mimicking the physiological hammock more closely. Between the outside and inside out transobturator sling, there's not much difference in the efficacy or the side effects of voiding dysfunction or urgency. But with outside in, there's a higher rate of vaginal angle and urethral injuries. So I've started doing initially 2003. I started with the sling, but then the obturator sling has come into clinical practice in our country in 2006. I started with outside in, and then I gone to inside out. That is my most favorite midurethral sling till date. So till date, I've done almost close to 500 midurethral sling. Initially for retropubic sling, during my learning curve, there were few occasions of bladder injury. There are no serious consequences or no long-term complications if we detect the bladder perforation intraoperatively and reposition the needle. In one patient with transobturator sling, the patient had neuropraxia. That means the first post-op day she couldn't adduct her leg. But fortunately, it resolved within 2 days spontaneously. So then I presume that it is probably because of perineural inflammation related to the foreign body. That is the mesh being in the vicinity of the obturator nerve. It is not a direct needle injury to the nerve. Otherwise, there wouldn't have been spontaneous resolution of a symptom. So I would just, it's a short video of 5 to 6 minutes. Of inside out transobturator tape, you can see the shape of the needle is different because it has to go through the obturator foramen. I'm marking the exit point for the needle. It is inside out. It is about 1.5 centimeter lateral to the groin crease. It's just a superficial nick I give at this point. And the next important point is we have to insert the tape under the midurethra exactly precisely. So start the incision about 1 centimeter proximal to the meatus, and the incision would go for a length of 1.5 centimeter on the anterior vaginal wall in the midline. So this corresponds to midurethra because 1.5 centimeter proximal to this point, we can feel the Foley balloon in the bladder. So I always instill saline adrenaline if the patient is hypertensive, plain saline, to dissect the parauretal tunnel. So the vaginal wall incision should be of optimal depth. We shouldn't dissect into the layers of the vagina. Then because the tape should be placed on the full thickness of the vaginal wall. And also we shouldn't go too deep because that will injure the urethra. So the dissection to create the parauretal tunnel is always sharp dissection. You have seen the scissors going in, and the scissors will touch the pubic bone and go beneath the pubic bone to perforate the obturator fascia. In the tunnel, this winged guide, we call it as a guide, is placed, and the tip of this guide goes into the obturator foramen. So now you can see the needle is placed on this groove over the surface of the guide. See here, the needle has gone into the obturator foramen over the guide, and once we know that the needle has entered the obturator foramen, remove all the instruments which are coming away and rotate the handle so that the tip comes out of the exit point which you already marked at the beginning of the procedure. Here you can see you take out the mesh on one end, leave it there for us to complete the procedure on the other side. See here you can see this is the groin crease. The exit point is even medial to the 2 centimeter point. This is called medial exit zone to increase the safety margin that I'll tell you later. See how you can see the winged guide is going in freely, and once it enters the obturator foramen, we will feel the loss of resistance. But did you observe at every point my index finger is going into the lateral fornix to make sure that there is no injury to the fornix. Here you can see before I pass it on the second side, there is a twist on the tail. I take my assistant's help to undo the twist because we don't want the mesh to be twisted under the urethra. That can cause urethral ischemia. Again, see how we get a click once the needle enters the obturator foramen. It goes over the guide. The guide guides the needle into the obturator foramen. Again, see my index finger is inspecting the fornix, palpating the fornix. Once the tip of the needle sheath comes out, we remove the handle of the needle by reverse rotation. Again, you observe my hand movement. So grasp the tip of the needle sheath and then bring it out. So now the most important aspect of the surgery is to adjust the tension. The tension on the tape now should be optimal, because if it is too loose, the patient will have persistent stress incontinence. If it is too tight, the patient cannot void after surgery. So always insinuate an instrument like a mesenform scissors between the mesh and the urethra so that there is no undue compression of the urethra. Once we are happy with the tension, you remove the outer sheath. You can see the outer sheath covering the mesh. So this should be done after the final tension is adjusted, because once we remove the sheath, we can't move the mesh because it clings onto the tissue. And we have to leave the instrument there till we remove the outer sheath, because otherwise it can get pulled and it can be tight under the urethra. You've seen that is how it should be at the end of the procedure. There is still some gap between the mesh and the urethra. And we now trim the excess mesh at the skin level. Those exit points do not require any suturing. We just apply a band-aid and leave it. If we are in the right plane, you have seen in the transobturator sling, there is hardly any bleeding. You can see how small the incision is. I'm not worried about the length of the incision, but this corresponds to the width of the parauretal tunnel. How much dissection you have done in that area is very important. I will talk about that point in the next slide. So, just 1 or 2 sutures to close the vaginal incision, either with chromic catgut or bicryl. And always make it a point to inspect the fornices at the end of the procedure. See, I'm using a retractor to inspect the fornices, again to rule out any vaginal angle injury, because if that is left unrepaired, if there was an injury and we haven't observed and we haven't repaired it, it will result in erosion, vaginal extrusion at a later date. So this point I wanted to highlight. See, this tunnel here is very narrow, just wide enough for the needle to pass through. So this to make sure that the periurethral fascia is intact, because this I believe is crucial in helping the mesh to get incorporated into the host tissue. Here this is the inside out procedure, and for this outside in, we have to use a finger to bring the needle into the vaginal incision. So this incision is slightly wider. So the periurethral fascia not only gets damaged, here there is a chance that the tape can migrate in the distance approximately. If the tape is not fixed under the mid-urethra precisely, the chances of success rates are lowered. This is a single incision mini sling, much less invasive than the standard midurethral sling, but it is not as effective as the standard sling. So why does a midurethral sling fail? Why does a patient have persistent stress incontinence? I won't go into the details. It could be because the patient is high risk. That means a patient, elderly patient, or the patient has intrinsic sphincter deficiency, or if we repair the prolapse concomitantly along with midurethral sling, the results are not as good as they would be in an index patient, or it could be a wrong diagnosis. If we inadvertently operate on a patient with, I had a patient who would be operated elsewhere for a neurogenic bladder who presented with symptoms of stress incontinence. She came to me with complete retention and I had to remove the sling. So proper preoperative evaluation, if required, urodynamic study is mandatory to avoid this type of diagnosing or operating on wrong patient. And failure of surgical technique. This is the most important factor, which would minimize all the complications. So to minimize the technical complications, the intraoperative needle injuries, we need to know the surgical anatomy well and strictly follow all the anatomical landmarks, because even slight deviation in the needle trajectory, especially in case of retropubic sling that Dr. Meera would highlight, I'm sure, would result in major complications. This is the landmark grossly. Here, this is the entry and exit zone for the transoperator sling, and this is the area of operator canal through which the vessels and nerve pass. We have enough safety margin. So if we stick to the anatomical details, there is the chance of injury are almost negligible. So to reduce the risk of erosion, the most dreaded complication of midurethral sling is erosion by the synthetic sling. We need to use good quality mesh, that is a macroporous mesh, which allows the fibroblasts and macrophages to grow through the mesh pores, and that helps in incorporation of mesh into the host tissue. And in elderly patients, postmenopausal patients, we need to give local estrogen before we put the mesh to avoid vaginal explosion. And the last but not the least, the most important is proper surgical technique. I mean proper surgical technique. By that, I mean minimal dissection in the paraurethral area, as I highlighted again and again. No tension on the mesh, no twisting of tape under the urethra. This results in urethral ischemia and erosion at a later date. Always inspect the fornices for any injury at the end. Cystoscopy is mandatory for retropubic sling and optional for transoperator. To conclude, if we adhere strictly to the standard protocols, we can minimize the complications and pass on all the benefits of these minimally invasive and highly effective surgeries to all those women who often suffer in silence. Thank you. And now, if any questions, welcome. You're on mute, Dr. Patel.
Thank you, Dr. Lalita.
Yeah,
that was very nice and exactly what we expected, what I mentioned in the beginning. Especially in a surgical line, the expertise is so important. Yes. And towards the end, also you highlighted a very important point that I think all surgical specialties should keep in mind: the respect for anatomy. Yes. I think anatomy is an evergreen thing, which even if we get into robotic surgery, we have to be very conscious of the anatomical landmarks. Yes. So thank you very much for that.
Thank you so much.
Now, can we, I would like to invite Dr. Meera with her talk. Dr. Meera, are you ready?
I am.
Yes. Yes, ma'am. The session is all yours.
Thank you.
You can start sharing.
Thank you, Dr. Lalita, for that wonderful talk and the video. I'm going to share in continuum the retropubic sling first and then go on to the overactive bladder. So it gives the kind of continuation for all the viewers to see the difference and compare and contrast both the procedures. Are you able to see?
Yeah, visible, ma'am.
Is it full screen?
No, ma'am.
No, right?
No, it's not a full screen yet.
Not a full
Okay,
screen.
give me 1 minute. It's important to stick on to the it's very important to stick on to the landmarks, as Dr. Lalita correctly pointed out. So at the outset, we're just showing how to set up the tray and how minimal equipment you need, instruments you need. You just need to be clear and don't clutter your trolley. This is exactly what you need, and this is minimal requirement, which is needed for doing this midurethral sling the retropubic vein. The landmarks is keep a finger on top of the symphysis pubis within a couple of centimeters on either side. The marking is done, and I
Sorry to interrupt
infiltrate.
you. Sorry to interrupt you, ma'am.
Yeah.
The video or the PPT is not showing.
No,
It's,
I've not started it. Only I'm talking.
Okay. I'm sorry. I'm
Yeah,
sorry.
I'm talking. I'm going to play it. So I'm going to infiltrate those landmarks with logs with as local with adrenaline and saline diluted. So it causes the hydrodissection of that space, and you're in the correct lane. And the tape is then deployed in the correct plane so as to avoid complications and injury to the viscera, and also prevent further protrusion or extrusion of the mesh. Now you're able to see?
No, ma'am. It's visible, but not full screen.
Full screen is not visible?
No, ma'am.
All the names of the slides, I mean, the entire slide list is, yeah, now that's gone.
1 second. It was playing before, right?
No, it wasn't playing. Yeah,
Visible
now
full
it's full screen and showing.
Again, this is sharp dissection. A thin Metzenbaum, a fine Metzenbaum scissors will do. If you go back and look in your theater, the Metzenbaum scissors has the fulcral point where the two flanges open up. The fulcrum point is about 4 centimeters length. That's exactly how much you will insert the Metzenbaum to open the space between the vagina and the urethral plane. So that will be the distance to the pubic arch as well. So everything has a reason why it is so. And if we stick to these landmarks, the minimization of visceral injury or injury to neighboring organs is very, very crucial, and correct. So that is why we use the specific steps and no cutting corners. And as you can see, the hydrodissection, staying in the plane, correct depth, all prevent any significant bleeding. And even if there is bleeding, the moment you deploy the tape, the bleeding stops. So don't worry about the bleeding. If you're in the right plane, your needle will go through correctly, sit well, you will avoid injury, you'll avoid bleeding. So the midurethral dissection for TVT retropubic is very minimal compared even to the TVTO or the obturator placement. It's hardly a centimeter. Ipsilateral shoulder. Aim towards the patient's shoulder so you get the exit point at the ipsilateral shoulder. As Dr. Lalita explained, cystoscopy is mandatory during a retropubic sling placement. After passage of the needle, I do a cystoscopy, then go back again, do the second one, do a cystoscopy, then finally one more cystoscopy. Use a 70-degree one so you see the lateral walls of the bladder correctly. Making sure the tape doesn't twist or turn. That will cause improper placement as well as no benefit for the SUI management. It's tension-free placement. So some instrument between the urethra and the tape is important. Always look at the urethra as well. Bladder neck, urethra, come back. And a tuovical suture, which is absorbable, is then put in to close the vaginal wound. There is no need for any suturing of the skin wound. You just put a band-aid and that is good enough. So that is pretty much the demonstration of a retropubic sling placement of a TVT mid-urethral sling. So with that, I'm going to move on to the, 1 second. The overactive bladder management. Are you able to see now?
Yes, ma'am, but not in full screen, ma'am.
Yeah. Now?
The file list is visible.
Okay.
Yes.
Now?
Yeah.
Yeah.
Yes.
Thank you. So Dr. Lalita had gone through what is stress urinary incontinence. I'll be going through very quickly what is overactive bladder. In contrast to urinary leakage or involuntary escape of urine with anything which causes strain on the bladder area or the abdominopelvic area, this happens with urgency. It can be associated with or without leak, and usually there is increased frequency of micturition as well. And it should be in the presence of no infection or any proven pathology, which could potentially lead on to overactive bladder. And many patients do suffer from nocturia as well. So more than half of our women and men do suffer from symptoms of overactive bladder, and prevalence is much more higher in women as compared to men. If we go through the micturition cycle, we have to remember one fact, that the bladder is a passive, compliant, balloon-like structure. It should not develop pressure while filling. That is the main schemata of things which will help storage phase of the bladder. So when the bladder is filling, there is a first sensation to void, and then a normal desire to empty the bladder, and a strong sensation to empty the bladder. And when the bladder emptying happens, there's contraction of the bladder, and subsequently the bladder is ready to get filled up again without building up pressure. This is the normal way that the bladder maturation cycle happens. Whereas in overactive bladder, the profound, strong urge can produce a very strong contraction, thereby causing leakage in the terminal filling of the bladder, or the bladder can be subjected to unprovoked or provoked contractions in between during the filling phase itself, which is again a variant from the normalcy and causes abnormal leakage even at smaller capacities of the bladder. The OAB can be dry or wet. Majority of patients complain of frequency and urgency, and they acquire a habit of frequent visits because they're scared they might leak. So 2/3 can be dry OAB and a third can be wet OAB. And we do not see pure stress incontinence or pure urgent incontinence. We do see in the Venn diagram a mixed type of incontinence where both can coexist, but one particular problem is predominantly symptomatic and has a serious impact on day-to-day routine and quality of life as well. There are various pathophysiologies which has been postulated for the causation of overactive bladder, having some sensor molecules which in the uroepithelial layer or in the muscle which causes hypersensitivity to the incoming signals, the abnormal response or the excitability of the afferent nerve pathway, and also central processing, and specific conditions like metabolic syndrome, diabetes, and inflammatory reactions can also lead on to overactive bladder. What do we look for? A very simple urine dipstick is good enough to rule out infections, protein crystals, and so on and so forth, and mainly to rule out blood and urine. Blood and urine can mean two things. One could be genital urinary TB, or because of carcinoma in situ or carcinoma bladder. We always look for post-void residual urine because if the patient has had a prostatic hypertrophy as in men, or in women a bladder outlet obstruction, they could have an already existing post-void residue and secondary detritus or overactivity leading to overactive bladder and thereby urgency, frequency, and leakage. Ultrasound to look for any obvious calculus or a clot inside the bladder of the kidney. And in cases who are not responding to initial management or refractory to treatment, we get on to do the urodynamic study. So the investigation for overactive bladder is simple primary care stuff where you can do just the urine analysis, post-void residual urine, and ultrasound to look at any structural abnormalities or any obvious pathology such as renal calculi. So what is the treatment? Anything first-line treatment is non-pharmacological or conservative. As far as the overactive bladder is concerned, is patient education and lifestyle modification along with behavioral therapy. It goes a long way to help them reduce their weight if they are overweight or obese, because it is noted by all the guidelines that even a 5% weight loss can go a significant long way in reducing more than 60% of the symptom and the improvement in quality of life in women suffering with overactive bladder. Pelvic floor exercises, especially the neck maneuver, helps in reducing the urgency-related leakage, whereby the pelvic floor muscle tone is improved and counteracts the unprovoked detritus or overactivity and prevents incontinence. Bladder retraining, whereby you have a scheduled training for these patients to go every 2.5 to 3 hours, so that the bladder enables itself to get better compliance and better holding capacity as the time goes on during therapy. Most important education is about their fluid management, to avoid excess fluid intake beyond 8 p.m. and to avoid any bladder irritant like fizzy drinks, caffeine, and tea goes a long way in the lifestyle modification which they need to ensure prior to going on to further invasive treatment. Understanding the fact that making these metabolic or lifestyle changes for life and continuing them and maintaining a healthy drinking habit along with their bladder retraining will be permanent and will increase the efficacy and success of any pharmacological therapy which is being instituted. We have pharmacological agents, mainly antimuscarinic or anticholinergic, a beta-3 agonist, which is mirabegron, which is kind of a lifesaver in many of our practices because it has lesser side effects, better tolerance, better compliance, and better adherence to the therapy, and therefore better success rates. The third line treatment is reserved for people who do not respond to a maximal or second line additional therapy, And for them, it will be botulinum intravesical injections or even a nerve stimulation with a sacral neural modulation or a posterior tibial nerve stimulation. Surgical procedures are reserved for those extreme cases with other problems and thereby leading on to augmentation, cystoplasty, and urinary diversion. We have to remember an augmentation cystoplasty will necessitate using clean intermittent self-catheterization. Otherwise, the patient can go into sepsis. This is very, very important to understand and very crucial part of counseling as well. So let us go through these management aspects very quickly. The medications which are available are these which specifically act on the receptors. The M3 receptor specific antimuscarinics are the agents of choice. So they do not have ubiquitous effects of the anticholinergic system and thereby causes profound side effects. So the antimuscarinic agents available in India are oxybutynin, tolterodin, solifenacin, darafenacin, trospium. Nowadays, we don't get the trospium, but it is a boon for those patients with neuromuscular problems because it does not cross the blood-brain barrier. It's a quaternary ammonium compound and has lesser side effects compared to those of the other antimuscarinic agents. We need to understand that the antimuscarinic receptors are ubiquitous in nature, present in almost all aspects of tissues of the body, and they have important side effects of action outside the bladder, and therefore these antimuscarinics can cause effects limiting their clinical use. An antimuscarinic agent is causing severe dry mouth or constipation means it is acting extremely well on the bladder as well. So, but unfortunately, the compliance is dictated by the adverse effects rather than the success of therapy. So, as I said, really bad dry mouth, blurred vision, cognitive dysfunction, and constipation. They can be confused, they can be disoriented. Acute angle closure glaucoma is an absolute contraindication for the antimuscarinic agents. So please take a proper history from these patients. I always go through their medication history and their prescription before prescribing any of these medicines because majority of the elderly patients have polypharmacy and they will be on other medication which itself can have profound anticholinergic effect. So it is important for us to know whether our medication is going to interact and increase the anticholinergic burden of this particular patient. So this is the study which was noting to find out the anticholinergic and non-anticholinergic. So they all found that the anticholinergic drugs were better than the placebo, but apart from dry mouth, was similar in effect. Transdermal oxybutynin caused less dry mouth than the other treatments, so may be worth considering as the first treatment. Antimuscarinic agents can cause urinary retention. That is why a postvoidal residue is important. If the postvoidal residue is slightly high, I tend to lean on the side of mirabegron because it doesn't affect the motor capability of the detrusor muscle and acts more on the afferent pathway and thereby will not reduce the contraction of the bladder and can be easily given. Intestinal hypomobility causing constipation, a precipitation of acute angle glaucoma, and myasthenia gravis. So do not combine agents which are otherwise potentiating muscle weakness like aminoglycosides. Duration of treatment, it improves symptoms within 1 to 2 weeks, but maximum benefit is achieved by 3 months. So if the woman or the man asks, how long do I need to take? The maximum effect will be seen at 12 weeks. They need to persist with that. Over 50% of the patients stop it within 3 months, either due to ineffectiveness, side effect, or cost. So adherence to antimuscarinic treatment is low and decreases over time because of this. And most patients will stop antimuscarinic agents within the first 3 months, which is why we have this advent of mirabegron. It's the first beta-3 adrenoceptor, once daily oral administration, reduces the frequency of micturition, incontinence, and urgency, having a significant improvement in the quality of life, sustains these improvements even after a year of therapy, and generally well tolerated. We know that the entire micturition cycle is the interplay of both sympathetic and parasympathetic systems. So, like noradrenaline, mirabegron acts on the beta-3 adrenoceptor, triggering detrusor muscle relaxation and improved urine storage. When the antimuscarinic act on the voiding and thereby reduces the contraction, the beta sympathomimetic agent act on the storage phase, improving the storage capacity of the bladder. So direct detrusor relaxation during the storage phase of the micturition cycle is bettered and thereby increases the bladder capacity, which no change in micturition pressure and residual volume, which is why if a patient has a higher residual volume, your mirabegron will be the drug of choice to go to in a patient with overactive bladder. I tend to use the usual adult dose of 50 milligrams per day because most of the studies have been with 50 or 100. I do not tend to use a 25 to start with. FDA approved mirabegron 25 milligrams to neurogenic detrusor overactivity in children and adolescents, and this was effective in pediatric patients. So adult dosage is 50. So patients with OAB can go on either of the anticholinergic or the beta sympathomimetic mirabegron. Depending upon their tolerability and compliance, you can switch over to the superior one. There has also been a study which shows the impact of body mass index on the treatment efficacy of mirabegron. That it shows that they do not conform to the usual hypothesis of body weight influencing the outcome of mirabegron. So it seems to act independent of that. The beta receptor agonist mirabegron improves glucose homeostasis in obese women, and that possibly could enhance better detrusor storage as well. We also need to consider dose modification or alternate medication if initial treatment is effective, but adverse effects continue. When there is such a condition, we then consider combination therapy. So when a patient is on antimuscarinic therapy, the side effects are tolerated well, but efficacy is not 100%. There is a tendency for people to double the dosing of antimuscarinic. Instead of that, we could combine the antimuscarinic along with beta-3 adrenoceptor agonist who are refractory to monotherapy with any of these medications. The reason being, then we do not augment the side effect profile of the antimuscarinic by double dosing. We are just adding a very stable beta sympathomimetic agent, which acts on the storage phase as well, thereby improving the therapeutic efficacy. The systematic review and the network meta-analysis where they compared the efficacy and tolerability of mirabegron alongside the antimuscarinic agent showed that mirabegron provides comparable overall efficacy to commonly used monotherapies with antimuscarinic agent. With regards to side effect profile, the study or the meta-analysis showed that the mirabegron appears to be better tolerated than the other antimuscarinics as well. Combination therapy of solifenacin and mirabegron, an effective treatment in patients who respond inadequately to first-line therapy and potentially reduces the number of patients moving to invasive treatment options. So if somebody does not respond to lifestyle and monotherapy, consider combining both the anticholinergic and mirabegron. They will respond significantly well and will avoid going on to the next treatment in the ladder. So this is very, very important because they act on different receptors in different systems. One acts on the storage, one acts on the voiding mechanism. So there was this study called Synergy study where evaluating the potential of solifenacin combined with mirabegron 25 or 50 to deliver superior efficacy compared with the monotherapy with acceptable tolerability. So in the largest OAB study, which is the Synergy study up to date, combined therapy with solifenacin and mirabegron 25 and 50 They provided consistent improvements in efficacy compared with the respective monotherapies. So it is superior. The most effects of combined therapy versus monotherapy were observable by first month itself. The clinical relevance of the improvements seen with the combined therapy for various objective outcome measures were also supported by improvements of combined therapy versus the monotherapy in the responder analysis. It is not only a subjective improvement, but it was also corroborated by several objective improvements of OAB in the combination therapy group, and most of the effects were superior than achieved by monotherapy, and all the effects were seen by the end of 1 month itself. The most important next study was to assess efficacy and tolerability of mirabegron versus antimuscarinic monotherapies and combination therapy. So mirabegron was as effective as the antimuscarinic therapy with fewer common bothersome side effects, and combination therapy of solifenacin and mirabegron was more effective than just mirabegron 50 milligram alone, but with more anticholinergic side effects. So we have now understood so far that mirabegron is tolerated better with similar efficacy to antimuscarinic monotherapy. Combination of mirabegron with antimuscarinic is superior to any other monotherapy in terms of therapeutic efficacy within a month with lesser side effects. Mirabegron has the same, if not lesser, side effects and same efficacy as antimuscarinic therapy. However, combination therapy has more side effects compared to just mirabegron alone. So these are the deductions we have understood from the various reviews so far. The most important study is out here from 2017, this BESIDE study, which to ensure safety and efficacy in older patients who are a major cohort of concern, who usually experience greater symptoms, severity, and comorbidities. So the patients remaining incontinent following a 4-week single-blind daily solifenacin were randomized into 1:1:1 to daily double-blind combination, and either with solifenacin and mirabegron 25 and increased to 50, and solifenacin 5 milligram or 10 milligram. There were 4 cohorts: less than 65, greater than or equal to 65, lesser than 75, and greater than or equal to 75. So it found that the efficacy and the safety in the overall population is maintained in older and elderly patients treated with a combination of solifenacin and mirabegron or solifenacin monotherapy, irrespective of age. Combination was associated with greatest improvement in the overactive bladder symptoms. I have to re-emphasize the fact that in practice, we all treat incontinence with a view to prevent falls and fractures attendant as a result of the falls. And that is mandatory in patients who are older than 65 and the most elderly patients. And this is a boon in terms of maintenance of continence, because a combination therapy, by reducing the symptoms or bothersome symptoms of overactive bladder, definitely reduces incontinence, definitely reduces fracture attendant due to falls. So the site of action, as we all know, is within the neuronal synapses system. And this is a picture which gives you almost all the medications so far available. We have fesoterodin also included. As you can see, the antimuscarinic side effects are there for all the antimuscarinic agents. One is not superior to the other. So mirabegron is a selective beta-3 adrenergic agent. It is now freely available in most countries. It's devoid of any anticholinergic adverse effects, but in a small proportion can cause abdominal pain, hypertension, and urinary retention. In cases who are refractory overactive bladder, we have these modalities in treatment where we can inject about 150 units of botulinum toxin. in multiple places in a template fashion within a bladder using a cystoscope. We do not use capsaicin or anything for intravesical therapy, but I do sacral neural modulation for those cases of refractory overactive bladder or over neurogenic bladder as well. The efficacy of the botulinum toxin can last for about 18 months. We cannot repeat the botulinum toxin within 3 months, and it cannot be done during pregnancy, but otherwise it is safe to resort to intravesical botulinum toxin. There have been studies now reporting that both botulinum toxin and neuromodulation have similar efficacy with regards to treatment of refractory overactive bladder. So as a carry-home, we need to educate and reassure the patient. No single anticholinergic is better than the other. Efficacy and side effects vary from individual to individual. It's okay to try different medication, but have realistic expectation. So this is not going to cure, but definitely control the overactive bladder symptoms. And we need to exercise caution while treating the patients who are elderly, because they can be having polypharmacy and can have serious interaction of the medication, leading to higher anticholinergic burden. So the take-home message is, given that we have very strong beta-3 adrenergics and anticholinergic, they have distinct mechanism of action. The combination of these medications is a boon for us to be able to treat a huge population with the refractory overactive bladder symptoms. Combination therapy provides satisfactory therapeutic effect without increasing the anticholinergic burden, thereby successfully improving the quality of life in the OAB patients. Combining mirabegron with solifenacin 5 mg is the recommended dose due to the balance achieved between efficacy and a tolerability which is acceptable in nature, reducing the incidence of side effects and thereby ensuring adherence to the treatment. Thank you.
Sir, mute. Sir, mute. Amit sir, you are on mute. Yes.
Sorry. Thank you, Dr. Meera. That was wonderful. And especially your opening remarks about no cutting corners. Very important for all upcoming surgeons to learn. And towards the end, the importance of using this combination therapy to minimize the side effects and increase the efficacy, especially in the more sensitive patients like the elderly, is a very important take-home message for everyone. Thank you so much for everything.
Most important is history taking and going through their prescription. Otherwise, we're not doing them justice.
Yeah, that's right. I think history taking is being relegated in the background usually. So I think it's very important to highlight that we get to learn a lot of those small nuances which help us to customize the therapy accordingly. So yes, that is a very important message for all of you who are listening. Please do not abandon history taking. Thank you very much. Jwalant, I will hand it over back to you.
Yes, sir. Thank you. Thank you so much. Thank you so much, Dr. Lalita, and thank you so much, Dr. Meera, for sparing your time and give your valuable insights regarding the clinical outcome with treatment and surgeries both. And of course, thank you so much, Dr. Amit Bhagav sir, for wonderful, coordinating between the two experts with us. And thank you so much, and have a wonderful evening. Thank you.
Thank you. Bye-bye.
Thank you so much.
Thank you, Patel and Dr. Amit, and thank you, Corona Remedies, for this.
Thank you. Thank you so much.
Thank you all.
Thank you.
Bye-bye.